Okay, so basically I've done a presentation on malabsorption. So I've done IBD, but also a few other things. So can anyone give me some like classic causes, GI causes of malabsorption at all? You can either shout it out or put it in the chat. Completely up to you. Anyone? I can't see the chat, so I don't know if anyone's written anything, but I'll just go through it. So we've got Crohn's, UC, IBS, and celiac disease. So Crohn's is a form of IBD, which affects anywhere from the mouth to the anus, but it's most commonly at the terminal ileum or colon, and you'll get skip lesions. UC starts, let me move that out of the way. UC starts at the rectum and never extends past the ileocecal valve. And it's continuous. You won't get these skip lesions. We also have celiac disease, which is an autoimmune disease, and then IBS, which is a diagnosis of exclusion. I've just seen the chat there and you said like pancreatic insufficiency. Yeah, so I was going to say, I haven't gone into like cystic fibrosis and like the pancreatic causes. I just kind of stuck to like your like classic bowel issues. Okay. Okay, so just a little case to start off with. So you're the 4th year med student in a GP clinic and a patient comes in complaining of abdo pain and altered bowel habits. What would you ask in the history to elicit history of presenting complaint? If you've got any ideas, just write them in the chat or shout them out. Just anything that you would ask in the history.
I will be reading from the chat. Nothing yet. So any questions you'd want to ask in the history? Duration.
Yeah, duration, that's fab. So how long has it been going on for? How often have they been getting it? Okay, so I'll go through the answers. So basically you want to start off with Socrates, the pain. If anyone doesn't know what Socrates is, just let me know. But yeah. Bowel habits. So when they say altered bowel habits, they mean diarrhea, constipation, both. Like you said, duration. So timing and frequency. How long has it been going on for? How often are they going a day? What is this compared to their normal? Is there anything mixed in with the stool? What's the consistency of it? Do they have any B symptoms? So weight loss, fever, lack of appetite. Is it related to anything they're eating in particular? Have they had any recent travel? Because obviously you want to rule out infection. Have they tried anything to alleviate the symptoms? Have they tried cutting any foods out? And also age is a really important factor. So if you've got a young patient, it's probably unlikely to be colorectal cancer, but obviously you have got to consider like hereditary things. And if you've got an elderly patient or like a middle-aged patient, it's unlikely to be Crohn's, but if they are middle-aged, there is a possibility that could be UC. And like I said, family history for IBD and colorectal. Okay, so IBD presentation. So UC.
Great. There's someone in the chat asking what are B symptoms?
Oh, sorry. So B symptoms are like secondary symptoms, which you can often get through like cancer or can also present with infection. So it's like fever, general malaise, weight loss, night sweats, kind of like when you're asking your review of systems, you'd stick them in at the end just to like red flag symptoms, basically. That's what they are. Okay, so UC presents with bloody diarrhea, abdo pain in the left lower quadrant, tenesmus, so that's the feeling that you like haven't fully emptied your bowels, uveitis, so inflammation of the eyes, and it can also present with primary sclerosing cholangitis. UC is most common in the age range of 15 to 25, and then like late to middle age, so 55 to 65. On the other hand, Crohn's is non-bloody diarrhea and you get this prominent weight loss. You also get upper GI symptoms because obviously it's from mouth to anus. So you can get ulcers and then you can also get perianal disease. And quite commonly they'll present with an abdo mass in the right iliac fossa. So if you get that in like a OSCE station or a history in an exam, it's kind of points towards that. These patients also present with gallstones, and they are usually younger, so it's usually before 20, but don't like rule it out if they're a bit older than that. Okay, and then common symptoms between the two of them, you get arthritis, erythema nodosum, pyoderma gangrenosum, lethargy, general abdo pain, obviously clubbing, and the change in bowel habits overall. Okay, if you have any questions or you want me to slow down, just let me know. Okay, so does anyone know of any like causes or possible risk factors for IBD? I know I've mentioned a couple before, but no? Okay. So genetics, it's linked to HLA-B27. So if that pops up in a question, it also points you towards IBD, as well as other things. And smoking, they're kind of like the two most prominent ones probably. It's also possibly linked to the combined contraceptive pill, a high sugar diet, deficiencies such as zinc, certain infections, and query NSAIDs. Okay, so if you are investigating IBD, there's kind of like 4 things that you want to look at. So you, first of all, you would want to do bloods. Can anyone think of any examples of bloods that you would maybe want to do if you're investigating IBD? Just type it in the chat.
Fecal calprotectin.
Fecal calprotectin is great. FBC, CRP, ESR, perfect. I do like a fuller slide next. The next is endoscopy, where you would take a biopsy, and then you also want to do radiology. Imaging wise, you want to do either a small bowel enema or a barium enema, depending on what your history is suggesting towards. That's not that commonly done, to be honest, but it's quite good for the description. What you see, it's like kind of like pathognomonic signs. So I'll show you those in the next one. So bloods wise, in Crohn's and UC, you'd both get this raised CRP and raised fecal calprotectin. However, in UC, you're more likely to get this positive P-ANCA antibodies than in Crohn's. And in Crohn's, you're more likely to get an iron deficiency anemia and low B12. Endoscopy, in Crohn's, you will see these deep ulcers, skip lesions, and this cobblestone appearance. I've got pictures of it on the next slide. And it would obviously be like throughout. Whereas in UC, you get kind of like widespread ulceration of the colon and these pseudo polyps. Biopsy wise, for Crohn's, you get inflammation throughout the layers and you get increased goblet cells. Whereas in UC, it's just, the inflammation is just up to the submucosa and you get depletion of goblet cells, and it's unlikely for you to get granulomas. Obviously you guys don't really need to know all of this off by heart, but if like it says in a question that this is what's seen on biopsy, that would kind of be helpful towards your answer. Radiology wise, so this is what I'm talking about. So small bowel enema, if you're thinking Crohn's, you want to do that probably. And if you're thinking UC, you're more likely to do a barium enema. And the specific signs that you'll see is you'll get this Cantor's string sign and rose thorn ulcers in Crohn's. And you'll get this drain pipe colon in UC, and I've got pictures of it here. So this is what you see on endoscopy and histology for the two of them. And then this is your Crohn's. These are these rose thorn ulcers. Probably not very easy for you guys to see, but if you just Google it, it's quite clear. They like kind of stick out literally like thorns. And then this is this Cantor's string sign, kind of where it like goes very narrow along here. And then this is your drain pipe colon, like you've lost kind of all the what they called, is it haustrations? Is that it? Okay, so management, I've gone into quite a lot of detail here because I made this for when we were doing our finals. So you guys, if you're not doing finals, like you don't need to go into this much detail. Basically, I've highlighted the like salient information. If you want to induce remission, basically you're using PRED, high dose steroids. If that's not enough, use azathioprine or methotrexate as an adjunct. And then if it's refractory, so it's not responding to therapy, use infliximab. So that's for Crohn's. If they do need surgery, it will be an ileocecal resection, most likely. And also for Crohn's, it's really important that the patient stop smoking, and this can like make the disease a lot worse. For UC, the management depends on the severity, which I've put up here. This is probably quite good that you have like a general understanding of, especially if you're getting to 4th year for your finals. So mild is less than 4 stools a day, and then severe goes up to greater than 6 bloody stools a day. Again, this one, you want to use aminocyclosate to induce remission, and depending on kind of how severe it is and where it is, it's either topical or oral. And if it's really severe, then you want to give them IV steroids first line. Okay. For maintaining remission, again, it's aminocyclosate, but it's topical rather than oral usually, unless, again, like I said, it's severe. The other thing is, if they have more than 2 exacerbations in the past year, even if it's not severe, then you would give it as oral rather than topical. Methotrexate is also not that useful in UC, but it's good in Crohn's. Okay, so you guys, it's probably more useful. I mean, this is quite good for exams and stuff, but for actual like OSCEs or LOCAS, which I assume that they still do on the new curriculum, you probably want to know like how to present it in an actual OSCE station. So if you were asked what would you do for the management of IBD, you want to break it down. So examination, you want to do patient obs and an abdo exam. Then you want to do your initial investigation. So if you're this if you're this student in the GP, you'd be doing bloods, as we mentioned previously, a stool culture and urinalysis just to rule out anything else. You then want to refer for endoscopy and biopsy, and also probably to gastro in general. And then treatment wise, I don't think you'd really be asked treatment in an OSCE for this, but if you were, it would probably be in regard to inducing remission. And so for that, I would just always say like high dose steroids, pred, hydrocortisone is always a good bet. And then just for extra marks like analgesia fluids, etc., supportive care. Okay. Complications of IBD. So Crohn's, you've got high risk of obstruction, which is typically why they have to have surgery. Fistula, gallstones, and colorectal cancer. However, in UC, you've got a higher risk of colorectal cancer and toxic megacolon. Okay, so I've got just a couple of questions now. They're like past med / finals style questions. So you've got a 22-year-old man with a 3-week history of diarrhea. He says that his bowels haven't been right for the past couple of months and he's had to run to the toilet often. These symptoms were improving until 3 weeks ago. He's also been passing some blood in his stool for a week and reports feelings of incomplete evacuation after going. He's no weight loss and has a good appetite. On examination, he has mild tenderness in the lower left quadrant, but he doesn't have any guarding. So what would be your top differential out of these? You can just write your answer in the chat. Yeah, fab. Okay, so yeah, UC is your top differential because his age and like the blood in his stool is probably your most like likely pointer. Oh, and the fact he hasn't had any weight loss, because that would more point towards Crohn's. Okay, next. So you've got a 48-year-old lady at a GI clinic for follow-up. She previously had treatment in hospital a month ago for an acute flare of UC. Currently, she appears well and does not report symptoms suggesting another flare. This was the second time she's been admitted to hospital in the last year due to an exacerbation of UC. In this case, what is the most appropriate maintenance treatment option for this lady? Again, you can just write your, just like A, B, C, or D is fine. If you're not sure, don't worry. Okay, the answer for this one was A. So it's oral because she's had 2 exacerbations in the past year rather than topical. Okay, so that's done with IBD. If you guys have any questions, just let me know. Now I'll move on to celiac disease. So celiac is an autoimmune condition caused by sensitivity to the gluten protein, and it affects about 1% in the UK. 1% of people in the UK. The most commonly seen thing is this villus atrophy, which is what is causing the malabsorption, and the villus atrophy is caused by the sensitivity to the gluten. It's linked with these genes, but you guys probably don't need to know that. Okay, so when to consider celiac disease. So basically, the NICE 2015 guidelines states that you should offer a serological testing for celiac disease for anyone who has any of these signs and symptoms, and it's not been explained by anything else. But the important thing to note is that when you are arranging testing, it's really important to tell the patient that they have to continue eating gluten as normal, or the result will be inaccurate, because if you've taken away the gluten, then they're not getting this villus atrophy, and so it won't be shown on biopsy, etc., etc. So basically what you have to tell them is they have to eat one meal containing gluten every day for 6 weeks prior to the test. And I think there are some separate rules for if they've cut it out for a while and they don't want to restart it again. I can't remember them exactly, but they were all on the NICE guidelines when I did this PowerPoint. Okay, so when you're investigating celiac disease, what might be some of the things you would be testing for, bloods-wise? Just write it in the chat. Yeah, anti-T2G is great. Fab. Yeah, so your first thing is serology. So you want to do total IgA antibodies, IgA tissue transglutaminase, which is TTG. And yeah, EMA, like you guys say, endomysial antibodies. Then you want to refer. So if these are coming back as positive, you'd refer to GI to arrange a biopsy. However, if these are negative and you still have a high clinical suspicion that they do have celiac disease, then you can just refer anyway, basically, as a GP. And then on your biopsy, like I said earlier, you would get this atrophy of the villi and flat mucosa, and you'd also get marked crypt hyperplasia and inflammation throughout. It can be similar to findings in UC, like I said, this inflammation and crypt hyperplasia, but your key difference is that you'll see this villus atrophy. And obviously you've got to consider the clinical history. They'll most likely be coming in saying, oh, whenever I eat bread, my stomach hurts, etc. So I thought I'd include a picture of normal, because it's always useful to have the normal to refer back to. But yeah, this is in a celiac small intestine. You get this scalloping sign, and then you've lost these villi. It's very flat here. Okie dokie. So management of celiac disease, very straightforward. Basically, you're maintaining a gluten-free diet. You can still eat rice, potatoes, and corn. And immunization-wise, basically patients with celiac disease will usually have some functional hyposplenism, because it's an autoimmune condition. So they'll need immunizations. So they get the pneumococcal vaccine and are given a booster every 5 years. And then some of them will also get a flu vaccine. I think it's probably based on age and other general health problems. Monitoring wise, they will always have an annual review. You'll get weight and height, a review of symptoms, and assess diet and consider whether they need to be referred on. If you are concerned as a GP, you should refer and arrange a DEXA scan. And if you have refractory celiac disease, so they've cut out gluten, and it's still ongoing, refer to GI at the hospital. And if it's really, really bad, then consider putting them on a low dose of prednisolone to kind of help them out until they get seen. Okay, so common complications of celiac disease, well, not common, but some complications that are commonly seen in celiac disease. You get this anemia, so you'll get iron, folate, and B12 deficiency, but folate is probably your most common. Hypersplenism, like I said before, osteoporosis or osteomalacia due to the malabsorption, lactose intolerance, T-cell lymphoma of the SI. This is quite like prominent for exams, like it comes up in past med quite a lot. Subfertility and unfavorable pregnancy outcomes, and then esophageal cancer. Doesn't really happen that often, but they're just at a slightly higher risk than the average population. Okay, and finally, IBS. So IBS is diagnosis of exclusion. So basically you have to rule out everything else before you can diagnose IBS. It should be considered if patients have any of the ABC symptoms. Does anyone know what the ABC symptoms stand for? You'd think of just like the classic symptoms that you would get with IBS. No? Okay, it's very straightforward. It's literally abdo pain, bloating, and change in bowel habit. This is all from the NICE guidelines, so this is how they phrased it. So if you do have these ABC symptoms, to actually diagnose it, you have to have the following. So you have to have abdo pain that's relieved by defecation, plus or minus, associated with an altered bowel habit, plus altered stool passage or abdominal bloating or symptoms while not eating or mucus in the stool. Obviously you can also get other symptoms with this, but like to actually diagnose it, they have to have the following. So when you are investigating IBS, like I said earlier, you have to rule out everything else. So IBD, celiac, gynae causes, because obviously bloating could suggest like an ovarian cancer or something. And also you need to screen for red flags, which are these B symptoms that I mentioned earlier. So investigations, NICE recommends FBC, ESR, CRP, TTG, and imaging shouldn't be necessary because basically you should be using all of these to rule it out. If any of these rule anything in, then that's when you would use imaging. And red flags, yeah, rectal bleeding, weight loss, family history of ovarian or bowel cancer, and greater than 60. For those of you who are in, I think it's 4th year that we did it, you'll have a CCT on red flag referrals, and that this like all comes up. You might have already had it as at the start of the year, I think. Okay, classification of IBS. So there are 4 types of IBS, and this is known as the Rome IV4 classification. So you've got IBS with constipation, IBS with diarrhea, mixed IBS, and unspecified. You don't really need to know these in much detail. Just know that there are, like, it can present in any kind of way. Like, it's not just that they have diarrhea. Okay, general advice for managing IBS. You want to have regular meals and not eat too fast. Avoid missing them, like kind of have regular snacks and stuff. Drink plenty of water. Don't drink too much caffeine or alcohol. Try to limit your high fiber foods and limit fruit, and increase your oat intake to help with bloating. So that's like non-medical management. Medical management depends on their main like symptoms that they're worried about. So if they've got pain, antispasmodics is quite helpful, diarrhea, loperamide, and then constipation, laxatives. It says avoid lactulose. I think it's just not very helpful for IBS. So if none of these have worked, then you can consider trialing a low-dose TCA and then review. But again, if that is still not working after 12 months, consider psychological therapy, because they're thinking that there's probably something else going on. Because if they've ruled out everything else and still not improving after that, then it's, yeah, you need to look for other causes basically. Okay, so now I've just got like a few questions, literally just to finish off. So you've got 28-year-old female presenting with oh yeah, sorry if you didn't know what TCA was, it's tricyclic antidepressant. 28-year-old female presenting with abdo pain and diarrhea, stools are frothy and difficult to flush. She's finding it hard to cope at work and has lost 5 kg over the past 6 months. Her blood tests show a normocytic anemia, and she's told she may have celiac disease. Which of the following is she most likely to be deficient in? You can just write the letter in the box. Okay. The answer is E. So, okay, someone said B. Yeah, so folate is the most common one, but they are most likely to be deficient in all of them. It's just that like folate is probably what they're most deficient in, if you get me. Question 4. A histology report for a specimen taken from the colon of a 24-year-old woman reports patchy areas of transmural non-caseating granulomatous inflammation. What disease process does this suggest? These are all past med questions, by the way. So, okay, this one is Crohn's. So yeah, the granulomas are most commonly seen in Crohn's, and because it's patchy and transmural as well, kind of gives the answer away. Okay, last one. So this is like a extended matching question. So 19-year-old female presents to the GP with a 4-week history of diarrhea. She mentions she's constantly hot and experiences occasional palpitations. She's unintentionally lost half a stone in weight in the last month. Does anyone know what the answer is? I can't actually remember what the answer was. Okay, so this, yeah, thanks, Janie. This is thyrotoxicosis. So it's a bit like a curveball. Yeah, so in thyrotoxicosis, you quite commonly will present with diarrhea, weight loss, and the thing that kind of pointed it towards thyrotoxicosis was the like feeling hot and the palpitations. It's the thing that fits the most here. Okay, next one. 46-year-old man presents with a history of sudden onset diarrhea, abdo pain, and fever. The patient says that his stool was very loose and mixed with significant amounts of frank blood. I'll give you a minute to read the options. H, yeah, so UC is the answer. So yeah, that points towards UC because of the blood, most likely. And I can't remember how old he was, but yeah, because he's 46. 14-year-old girl is brought in by her mother to the GP, who says that her daughter has been going to the toilet up to 6 times a day over the last month. On examination, the girl is underweight, has downy hair on her arms and face, and there are scratches on the knuckles of her right hand. This one's quite straightforward. Anyone? Okay, this one is C, laxative abuse. So yeah, it basically points towards anorexia nervosa because of the scratches and the hair on her arms and face. I can't remember now what those actual signs are called because I haven't done it for like 3 months, but they're like classic signs of anorexia. Okay, I skipped that one, but it's IBS. And then the last one, an 80-year-old woman who is cared for in a nursing home is noticed to be passing watery diarrhea despite the fact that she's known to be chronically constipated and fecally impacted. I don't know what the answer to this one is. Yeah, overflow diarrhea. Okay, so thanks guys. That was my presentation on malabsorption. If you have any questions or anything, just let me know. And I think Mon's uploading this to YouTube, so you can go back through it. But if you want the slides or anything,